Hello Medicos, good day to all of you. Today I will be discussing about the stomach. So the stomach is one of the very important organ in the gastrointestinal system, or you call it as GIT, gastrointestinal tract. So we all would have been discussed and read about the stomach right from our school days. So this class is actually going to be about the elaboration of the anatomical facts which you are already being exposed to or introduced to in your earlier schooling period. Now, with respect to the stomach, today we will be discussing about this organ. First, a short introduction about the purpose of this organ. Followed by that, we will be discussing its situation, that is the location, then what is the normal shape and what is the capacity of the stomach. Followed by that, external features, that is the presenting parts, the various parts of the stomach, its relations, visceral as well as the peritoneal relations, and then we will have a very short discussion about the interior of the stomach, and then finally the blood supply, lymphatic drainage, nerve supply, and we will conclude this session with the discussing about the applied aspects. Now, first of all, when we actually talk about the stomach or think of the stomach, what actually comes to our mind? When we think of the region abdomen itself, immediately what crosses our mind is the stomach. It is the most distensible part of the gastrointestinal tract, which means most dilated or expanded part of the gastrointestinal tract. It stores the food. The food stays at an average of 3 to 4 hours for digestion. You all know that, and it depends upon the nature of the food we take. Suppose if it is a simple carbohydrate food, then it is emptied very fast or rapidly. Protein food takes more time, and of course fatty food, foods rich in fat, are actually present in the stomach for a longer period of time. So we all know the stomach secretes HCl, hydrochloric acid, and the hormone gastrin. So this is mainly responsible, this hydrochloric acid and the hormone gastrin is again responsible to actually regulate the secretion of pepsin, and this is required for the digestion of proteins. So it breaks down the proteins into proteomes and peptases. So that is the main function of the stomach. So it also, an elaborate intrinsic factor is throughout the stomach, it is can be seen. Now this intrinsic factor, what happens is, helps to absorb B12 from the intestine. Okay, so mainly what happens is, so for the absorption of B12, we all know that B12 is very much essential for the bone strength. Okay, so intrinsic factor helps in absorption of B12 not in the stomach but in the intestines, but it is elaborated in the stomach. Then to some amount, some of the substances are directly absorbed in the stomach. We all know that the small intestine has villi for absorption, so where actually the most of the absorption of nutrients takes place. But water, alcohol, some of the drugs, all those things are actually absorbed in the stomach. Same, the stomach also excretes certain substances, and the urea is actually to some amount excreted in the stomach. Then we all know that stomach secretes a lot of mucus, the mucosal cells. This is very much essential to protect your stomach wall from the erosion of the hydrochloric acid. So, a lot of mucus is actually secreted, and this mucus also prevents bacterial invasion because stomach stays in the food for a longer period of food stays in the stomach for a very longer period of time. So naturally what happens is there is a very high chance of the microbial growth, and this is actually prevented by the mucus secretions, which does not stick onto the wall, any microbes. So now coming to the situation of the stomach, we all know that we have already discussed in the first class of the abdomen itself. Your abdomen is divided into 9 regions. So by looking at this picture, you can very well come to a conclusion that stomach mainly occupies the epigastric region. So epi means above. So epigastric region. Then it also extends below the left costal margin, that is the left hypochondrium or hypochondriac region. Okay, so hypochondrium means below, chondrium is cartilages. Okay, so because the anteriormost part of the rib actually is formed by the cartilage. So epigastric region, hypochondrium, and it also extends to somewhat into the umbilical region also, especially when the stomach is full or distended. It definitely occupies or enters into the umbilical region. So that is the topographical situation of the stomach. Now size of the stomach, so the average size, even though it differs from person to person, on an average the capacity of the stomach is 1 to 1.5 liters, that is 1000 to 1500 ml. In an adult stomach, it is 1 to 1.5 liters, that is the capacity of the stomach. In newborn or neonates, it is just 30 to 50 ml, that is the actual capacity of the stomach in the newborns. It is only just 30 to 50 ml. Now, even when the stomach is empty, there is air. Okay, so in the fundus actually what happens? Gas. We call it as a funding gas, which is usually present, the normal content of the stomach, even when the stomach is empty. So that is because this air is mainly due to the ingestion. We ingest air when we take food. Okay, or when we open our mouth and speak, at that time some of the air actually goes into the stomach, and there what happens, it stays in the fundus of the stomach. Now, with respect to the shape of the stomach, the most common type is actually the sphenic stomach. Basically, the stomach is J shaped. Okay, so this is actually the long limb of the J, and that is actually the short limb of the J. Capital letter J, you can actually imagine. So that is the longer limb of the J. In a normal sphenic stomach, the long limb of the J is slightly oblique. That is called a sphenic stomach, and you come across mainly in 50%. The next type of stomach, what you see is the hypersphenic stomach, where the long limb of the J is very oblique or slanting. Okay, it is very much oblique and it is called as the hypersthenic stomach. Now, because it is very much oblique, all the contents, what happens, they are moving towards the duodenum. That is why they are more prone for duodenal ulcers. The secretions, they don't stay in the stomach, they actually tend to go into the duodenum. The next type is actually asthenic or hyposthenic. Okay, asthenic or hyposthenic. But some books actually describe asthenic separately and hyposthenic separately, but there is not much difference between these two. In this type of stomach, what you see here is the long limb of the J is very much vertical. Okay? It is not slightly oblique or it is not too much oblique, it is straight vertical. And naturally the secretions, what happens, tend to stay in the stomach for a longer time, and these people are more prone for gastric ulcers. So the normal type is the sthenic type of the stomach. The next is the hypersthenic, and the other type is the hyposthenic. It's all based on the how the long limb of this J is present. Now we will come to the parts or the external features of the stomach. So the two ends of the stomach you see here, the stomach has two ends. One is actually called as the cardiac end and other one is actually called as the pyloric end. Pyloric, the pylorus of the stomach is present. Cardiac, since it is present near to the heart, it is actually called as the cardiac end. The cardiac end, if you look this end, it is not very much thick. The wall of the cardiac end of the stomach is not much thicker, it is thin and it is not that much mobile, it is fixed. It is immediately present following the esophagus, the cardio-esophageal junction. Okay, so that part is fixed and immediately below the diaphragm. It is 2.5 centimeters to the left of midline. So from the midline or median plane, just you take to the left side 2.5 centimeters. There you see the cardiac end of the stomach. That is the surface marking. The level of 7th costal cartilage. Okay, at the level of 7th costal cartilage, and vertebral level will correspond to T11. T10, esophagus will pierce the diaphragm. The left crus of the diaphragm, the esophagus pierces, and the 11th vertebral level, thoracic vertebra, the esophagus actually what happens is making contact with the cardiac end of the stomach, that is the cardio-esophageal junction. And anatomically, you don't have a sphincter. So there is no thickening. You are able to see the longitudinal and circular muscle coat of the esophagus is continuous along the cardiac end of the stomach. So as such, anatomically there is no sphincter at the cardiac end. You don't have a cardiac sphincter, but physiologically they tell cardiac sphincter it is present. Functionally there is a sphincter which should definitely prevent the reflux or regurgitation of the gastric contents into the esophagus. Okay, so the physiological sphincter, as we told, regurgitation is prevented by the following two factors. One is the circular muscle of the esophagus itself contracts to prevent any regurgitation, and other support is actually given by the left crus of the diaphragm. The right crus, because the diaphragm has three major openings. The inferior vena cava actually makes an opening or pierces through the central tendinous part, and the abdominal aorta, the next major opening, is actually not an opening at all, it is a gap between the T12 vertebra and the diaphragm, osteoaponeurotic opening. Whereas it is the esophagus at the 10th thoracic vertebral level pierces the musculature of the diaphragm between the vertebral fibers of the diaphragm, forming the right crust of the diaphragm. So that to some extent what happens as a contracting effect on this gastroesophageal junction, the lower end of esophagus, it is pierced. So this wavering line, zigzag line you see here is the esophageal and the gastric mucosa merging. That is the line of merging of the gastric and the esophageal mucosa. That is the gastroesophageal junction. So we have discussed about the cardiac end of the stomach or cardiac orifice, which is seen at the level of the 7th costal cartilage. The next end, what we see here is the pyloric end of the stomach or the pyloric orifice, which is 1.25 centimeters to the right of the median plane. So this, you are able to almost a little bit nearer to the median plane, almost half the distance of the cardiac end, but it is to the right of the midline or the median plane. It is more mobile, fixed, and it is thick. Okay? More thicker when you just touch and feel the pyloric orifice in a cadaver specimen. You can very well appreciate the pyloric end, which is more thicker, more mobile, it is movable, whereas the cardiac end is somewhat fixed. So here you are able to see the thickening of the pyloric sphincter. So anatomically there is a sphincter which is present due to the reduplication of the circular muscle. Okay. So the wall of the stomach is made up of musculature, smooth muscle. You have longitudinal, circular, and also you have an oblique muscle. So that will come to it while dealing with the interior of the stomach. The circular muscle is thickened at the level of the pyloric sphincter and mainly responsible for the formation of the pyloric sphincter. And it is also contributed by some fibers of the longitudinal muscle also. The major contribution is from the thickening of the circular muscle. So as I told, it's more mobile and identified in the living by the prepyloric vein of Mayo. So prepyloric vein is actually again unique to the stomach. You don't have an accompanying artery. There is no corresponding artery for the prepyloric vein of Mayo. And in the dead persons, the pyloric end can be identified because it is usually stained with the bile. Now, we will pass on to the parts of the stomach. So, basically, the stomach can be divided into three parts: fundus, body, and pylorus. Okay. So, it has the fundus, you have the body, and then you have the pylorus. Now, how actually you demarcate fundus from the body? If you draw a horizontal line from the cardiac end of the stomach transversely or horizontally up to the greater curvature. So you connect the cardiac notch and the greater curvature. The part above this horizontal line is actually the fundus. Okay. And as I told you, gas is actually a normal content of the fundus even when the stomach is empty. And the summit, the highest point of the fundus, can reach up to the 5th intercostal space. Okay. So immediately above the 5th intercostal space, what you have at the level of 5th intercostal space, above the diaphragm, immediately above the diaphragm, you will have the apex of the heart. Okay, so the apex of the heart, and this is mainly separated. The summit of the fundus is just separated by your diaphragm. Of course, above the diaphragm you will have the parietal pleura, and below the diaphragm you will have the parietal peritoneum. Okay. Lung does not intervene at this place because the heart is there. Naturally, the lung should be more lateral. Fundus. Okay. When you draw a line from the cardiac notch to the greater curvature, above that is the fundus of the stomach. The next is actually the body of the stomach. From the horizontal line, then you draw a vertical line from the incisura angularis to the greater curvature. Okay. You draw a line from the incisura angularis, it's written as angular incisure. Now, what is incisura angularis? If you trace this border, the lesser curvature of the stomach, and it makes an acute angle. Okay. Suddenly from the oblique or vertical part, it becomes horizontal. So at that point, it makes an acute angle, and that is actually called as incisura angularis. From that, you draw a line towards the greater curvature that demarcates the lower limit of the body of the stomach. So the body is lifted above by the first imaginary line I told you, and below the line connecting the incisura angularis to the greater curvature. Okay. There you have again a sulcus which is called as the sulcus levitans. And that part of the greater curvature, is actually bulging a little below. So that is about the fundus of the stomach, and then I have discussed about the body of the stomach. Next we will come to the third part, which is the pylorus of the stomach. Pylorus, total length of the pylorus is 10 centimeters, and it is subdivided into pyloric antrum and pyloric canal. Pyloric antrum and pyloric canal of the total 10 centimeters. Okay. Pyloric antrum measures around 7.5 centimeters and canal is around 2.5 centimeters. Antrum is that part, as I told you, which is somewhat bulged inferiorly. The greater curvature makes a distension or bulge. That part is actually the pyloric antrum. Then followed by what we have is the pyloric canal, and both are again separated by a sulcus which is actually called as the sulcus intermedius. Sulcus intermedius, which separates the pyloric antrum from the pyloric canal. Then the pyloric canal ends in the pyloric sphincter. So some books also gives pyloric part of stomach consists of the pyloric antrum, pyloric canal, and then the sphincter itself, the pylorus or the pyloric sphincter. So stomach mainly consists of the fundus, body, pylorus. Pylorus is actually divided into pyloric antrum, the bulged part, and then the pyloric canal. Both are again separated by the sulcus intermedius. Now coming to the curvatures of the stomach. So two ends we have seen, pyloric end and the cardiac end. Two curvatures, lesser curvature and the greater curvature. So this is actually the lesser curvature you are seeing, which also forms the right border of the heart. The lesser curvature forms the right border of the stomach, right border of the stomach. It is situated slightly at a posterior plane, more posterior as compared to the greater curvature. So it forms the right border of the stomach. On the lesser curvature, as I told you, the most dependent part is the incisura angularis. So from there we have drawn an imaginary line downwards, and that demarcates the body from the pylorus. Incisura angularis, most dependent part along the lesser curvature. What is attached to the lesser curvature is the sport of peritoneum, that is the lesser omentum. The lesser omentum, the two layers, which is extending from the liver. From the liver to the lesser curvature, you have this lesser omentum, a double layered fold of peritoneum. So already we have discussed much and enough about these peritoneal folds. So between these two layers, what you have is the anastomosis of right and left gastric vessels. So that is both the arteries and the veins. So we have the anastomosis of the right and left gastric vessels along the lesser curvature, but between the two layers of the lesser omentum. Now, if you look along the lesser curvature, there is a narrow passage which is called as the gastric canal, which is called actually the gastric canal. Now, what is the importance of the gastric canal is any fluids, mostly the fluids, water or whatever fluids we drink, fruit juices, alcohol, all those things, they readily pass along the lesser curvature. Okay. This lesser curvature is bounded by two lips, which is formed by the approximation of the oblique muscle. The oblique muscle failed to reach the lesser curvature. Okay, it is only lined by the circular and the longitudinal muscle. So fluids actually pass along this lesser curvature, and it is called as the gastric canal. So nowadays one surgery is performed which is called as the bariatric surgery. So what do they do in the bariatric surgery? The bariatric surgery is actually done to persons who are obese, mainly morbidly obese. So they are very much obese. Their body mass index is too high. Those persons, when they can't control the weight, when they can't reduce the weight or any dieting plan, everything fails, then they go for this bariatric surgery, which means they remove most of the stomach. Okay, and only along this gastric canal, as I told you, only that part of the stomach is retained and the remaining part of the stomach is removed. So thereby what happens is they take only the fluids. Okay, so that is about the lesser curvature. Next is the greater curvature. The greater curvature, as I told you, is situated somewhat in a more anterior plane as compared to the lesser curvature. It forms the left border of the heart, left border of the stomach. It is 3 to 4 times extensive or larger than the lesser curvature. It usually starts from the cardiac notch and extends upwards and left, and then it turns downwards and towards the right. So from the cardiac notch, when it runs upwards and to the left, it is forming the fundus, upper limit of the fundus, and also summit of the fundus it forms. So as I told you, it continues downwards and to the right up to the pyloric end or the pyloric orifice. So that is about the greater curvature. Along the greater curvature, mainly it gives attachment to some peritoneal folds. Near the cardiac end, we have the gastrophrenic ligament. Okay, the gastrophrenic ligament extends from behind the cardiac end of the stomach to the left crus of the diaphragm. Okay, to the left crus, from the cardiac end to the left crus is the gastrophrenic ligament. Now, the stomach is very much an intraperitoneal organ. So it is covered by peritoneum in the front and behind. But there is a very small area behind the cardiac end of the stomach which is not covered by peritoneum, and it is directly related to the diaphragm. Okay. You have a very small bare area of the stomach, even though it is completely intraperitoneal. Okay. So that is about the gastrophrenic ligament. Then next to that, along the fundus, mainly what you see is the gastrosplenic ligament, which extends from the upper part of the greater curvature to the spleen. It is running towards the hilum of the spleen. It is called as the gastrosplenic ligament, and this transmits your short gastric arteries from this splenic artery. The content of gastrosplenic ligament is the short gastric artery. Gastrophrenic, phrenic refers to diaphragm, so it is attached to the left crus of the diaphragm. Then the remaining major part of your greater curvature gives attachment to this fold of peritoneum, that is the greater omentum. Okay, so gastro or greater omentum, rest of the greater curvature, and the epiploic arteries, the right and left gastroepiploic arteries, anastomose within these two layers, within these layers of the greater omentum. The first two layers, because then these two layers again they turn back to form the third and fourth layer, and it is related to the transverse mesocolon. Posteriorly, the greater omentum is related to the transverse mesocolon, that is the peritoneum of the transverse colon. So we have discussed about the lesser curvature. Attachment is the lesser omentum, which contains the right and left gastric arteries. Greater curvature, mainly greater omentum, anastomosis of right and left gastroepiploic arteries. So two orifice or ends, two curvatures, and then you have two surfaces. So first surface is the anterior-superior surface. So this surface, what you are viewing, is the anterior-superior surface of the stomach. It is actually covered by the peritoneum, and it is related mainly, if you look at the right part of the stomach or along the right border, you can tell it is related to the left lobe of liver, and near to the pylorus it is related to the quadrate lobe of the liver. So it is related to the left lobe, and then it is related to the quadrate lobe. Quadrate lobe immediately next to the fossa for the gallbladder. Immediately to the left of the gallbladder, you can see the quadrate lobe of the liver near the pyloric gate. Then here the fundus and upper part of the body is actually related to the left costal margin. Left costal margin. Then interior to it, it is related to the diaphragm, and above the diaphragm it will be related to the left lung. Okay, so above the diaphragm it will be related to the left lung. As I told, fundus, as I told you, it reaches up to the fifth intercostal space. So here you can see the apex of the heart. So left costal margin and the diaphragm, the left part, upper left part. Then this part, what happens, is related to the transverse colon with its peritoneal covering, that is the transverse mesocolon. When the stomach is empty, the transverse colon will come to the lower part. If the stomach is full, then naturally it gets distended, and it will, transverse colon will be pushed downwards. Okay. Now, liver, costal margin, and the transverse colon. So there is an area in the anterior superior surface which is not related to any viscera, and it is in direct contact with the anterior abdominal wall. This triangular area is in direct contact with the anterior abdominal wall, and that is called as the gastric triangle. First we have seen about the gastric canal. It is called as gastric canal of Megentres. Now we are actually discussing about the gastric triangle. Now if you look at this gastric triangle, the boundaries are, as I told you, the left costal margin, then the left lobe of liver, and lower part the transverse colon or the transverse mesocolon comes in relation to it. In between, it is directly related to the anterior abdominal wall. So that is, we are discussing about the gastric canal. Okay. So now what is the usage of this gastric canal is, if there is any obstruction in the esophagus, then the patient, when he cannot swallow, so any fluids or solid food cannot be administered in case of obstruction, carcinoma of the esophagus and all those things, then gastrostomy, an opening is made to the anterior abdominal wall, and what happens is feeding is done through this opening. So that is the significance of the gastric triangle. Next, on the anterior superior surface, we also have a space which is actually called as the Tropp space. This is also again clinically an important space. First, let us try to understand the boundaries of this space. So it is roughly semilunar in shape and covers the fundus and upper part of the body, which is called as the Tropp space. It is actually, as I told you, semilunar in shape, and mainly the upper margin is formed by the left lung, lower border of the left lung. Lower margin is actually formed by the left costal margin. Okay, so the left costal margin, and to the left it is limited by the spleen, and to the right by the lower border of the liver. So the lower border of the liver to the right and spleen to the left side. Now this area, what is the importance of the Tropp spaces? It is tympanic on percussion. So when you just tap that area, you should get a resonating note. Instead, if the note is not resonating, if you get a damp note on that area, so that means that space is obliterated. It is reduced mainly because some effusion, collection of fluid, mainly pleural effusion, since lower border of the lung might reduce this space, or the liver would have enlarged hepatomegaly, that would have obliterated or reduced this space, or the splenomegaly, if the spleen would have enlarged, and naturally that would have reduced its space. Okay, the Tropp space will get obliterated if the effusion due to pleura or hepatomegaly or splenomegaly. So that is about the Tropp space, which you again see on the anterior superior surface of the stomach. So next, coming to the posterior inferior surface of the stomach, that is behind the stomach, there are so many structures which are present on the posterior inferior surface. It is related mainly to the left crus of the diaphragm. This is right crus. You are able to see the opening of the right crus, the esophagus. Here you see the left crus of the diaphragm, left suprarenal, left kidney, body of pancreas, and running on top of body of pancreas is the splenic vessels, then spleen. Okay, so mostly in an empty stomach, spleen also comes behind the stomach, and then the transverse mesocolon. So that cut line you are able to see is the transverse mesocolon attachment. So these are the structures which is present within the stomach, and it is called as the stomach bed. So stomach bed structures means left crus of diaphragm, left suprarenal, left kidney, body of pancreas, splenic artery, spleen, and transverse mesocolon. Okay, all these structures are separated from the stomach by a space behind the stomach, which is called as the lesser sac. Okay, so the lesser sac is actually a reserved space for the stomach. When it is distended, it will be occupied, and that space will also get reduced. So that is about the posterior-inferior surface, and mainly what you should remember on this surface is the stomach bed structures. Interior of the stomach, when you look at the interior of the stomach, what you see, it is thrown into number of folds. The mucosa mainly forms the food. So layers is mucosa, then you have the submucosa, then you have the muscularis externa, followed by the outermost covering, the serosa. Serosa is mainly formed by the peritoneum. Mucosa is thrown to number of folds, and that is actually called as the rugae. Okay. Then in the depth, you can see in between the mucus you have pits or indentations, gastric pits, which receives the openings of the gastric glands. Okay, so you have glands in the fundus, funding glands you call it as, you have glands in the pylorus, you call it as the pyloric glands. So the glands open into the pits, okay, in between the rugae. They are called as the gastric pits. The musculature of the stomach is mainly in the form of three. Usually in the GIT you have inner circular and outer longitudinal. But here we have three layers. They are disposed in the form of three layers. You have mainly the outer longitudinal coat of the stomach, longitudinal muscle layer. This longitudinal muscle layer is continuous. You are able to see it is continuous with the esophagus. When you trace it beyond the pylorus, the superficial muscles of the longitudinal layer is continuous with the duodenum, but the deep layers do not cross the pyloric sphincter and go to the duodenum. They actually reduplicate and merge with the circular muscle fibers to form the pyloric sphincter. Okay, that is about the longitudinal muscle layer. The next is the middle circular muscle layer. Middle circular muscle layer. Above again continuous, you are able to see circular muscles beyond the cardioesophageal junction. It is continuous, the circular muscle of the esophagus. But below definitely does not cross the pylorus. It reduplicates and thickens to form the pyloric sphincter. The next layer, the inner oblique layer, it is in the form of series of inverted U shape. They form a U-shaped loop. Starting from the greater curvature, you see they form U-shaped loop, and up to the cardiac's notch you can see. It is the border of the limit of the oblique muscle. Beyond that, along the lesser curvature, the oblique muscle is absent, and we told you that is the gastric canal where the fluids directly pass over this lesser curvature. Okay, so they are mainly responsible for circular muscle to retain the contents. Okay, oblique muscle is mainly for propulsive actions, so churning the contents. The contents are actually uniformly made into uniform consistence, which is actually called as the chyme or the chyme. So you have outer longitudinal, middle circular, and you have an extra inner oblique muscle for the stomach, the interior. Now coming to the blood supply of the stomach, it is mainly the branches from the celiac trunk, because stomach is a foregut derivative and the artery of the foregut is the celiac trunk or the celiac artery. So right and left gastric arteries anastomose along the lesser curvature. Left gastric direct branch from the celiac trunk, Right gastric is from the common hepatic artery. Right gastric is from the common hepatic artery. Then you have the right and left gastroepiploic arteries along the greater curvature within the two layers of the greater omentum, the anastomosis. Left gastroepiploic is a branch from the splenic artery. Right gastroepiploic is a branch from the gastroduodenal artery. Okay, from the gastroduodenal artery, we have the right gastroepiploic. Actually, it is given as omentum. Nothing but the right gastroepiploic artery. Then you have the short gastric arteries, mainly which supplies the fundus. Short gastric arteries, they are again branches from the splenic artery. Short gastric artery are actually branches from the splenic artery. Okay, they give gastric. Sometimes, occasionally, you also have a posterior gastric artery. Then, coming to the venous drainage, we have the right gastric vein and the left gastric vein. They directly drain into the portal vein. Okay, this is actually the portal vein. All the venous blood from the gastrointestinal tract is actually carried by the portal vein, and they open into the liver, and finally, after piercing the liver, they open hepatic veins into the inferior vena cava. So, right and left gastric vein draining directly into the portal vein. Left gastroepiploic and short gastric into the splenic vein. Left gastroepiploic and short gastric veins, they will drain into the splenic vein, whereas the right gastroepiploic vein drain into the superior mesenteric vein. Is draining into the superior mesenteric vein, right gastroepiploic vein. Then you have one more vein, the pre-pyloric vein of Mayo, that also drain into the right gastric vein. Pre-pyloric vein of Mayo drains into the right gastric vein. So that is about the arterial supply and the venous drainage of the stomach. Then we are coming to the lymphatic drainage. If you look at the lymphatic drainage, if you draw a vertical line from the fundus, then you can divide the whole of the stomach into the left part, the right part, and then the pyloric part. So pancreatico-splenic lymph nodes, which are seen on the upper border of the pancreas, behind along the splenic vessels. Pancreatico-splenic nodes behind the stomach. I told you along the upper border of the pancreas, along the splenic vessels you can see. So mainly drain the fundus and upper part of the body of the stomach. The left part, mainly the upper part, is actually along the lesser curvature, and the remaining upper part of this left part of the body and fundus is drained into left gastric nodes, upper 2/3 of the right part. Okay. The left part of the fundus and body is actually drained into the pancreatico-splenic nodes. The right upper part is actually drained into the left gastric nodes. Then you have right gastroepiploic nodes, which drains the lower part of the body. You have the right gastroepiploic nodes. Okay. Then the pyloric part is actually drained into the pyloric nodes, or some call it as subpyloric nodes. Some might bypass and go to the hepatic nodes, and some might directly go to the left gastric node. So pylorus mainly drain to pylorus or hepatic, and then left gastric nodes. Now ultimately all these nodes finally drain into the celiac nodes. Okay. Whether it is pancreatico-splenic or left gastric or pyloric or right gastroepiploic nodes, they finally drain into the celiac nodes. So lymphatic drainage is very important because of the carcinoma of the stomach, how the carcinoma spreads. Then you should know which are all the lymph nodes involved. So carcinoma spreads to esophagus, but does not spread to the duodenum. That is because the lymphatics, they communicate with the lymphatics of the esophagus, the gastric lymphatics. So lymphatics, they actually start as the radicals subepithelium, then they form a plexus below the epithelium, subepithelium. From there, submucosa, they will again form a lymphatic plexus. Then what happens is, then they will form in between the musculature, and finally the lymph vessels pierce the wall of the stomach and drain into the following lymph nodes. Okay. The lymphatics of the stomach communicates with the esophagus, but they don't communicate with the duodenum. Why they don't communicate is because submucosa, there is a connective tissue septum which separates the pylorus and the duodenum. So the lymphatics cannot cross to the duodenum. Second thing, the musculature, we have already seen the circular muscle and the longitudinal muscle are continuous with the esophagus, whereas the circular muscle and the deep part of the longitudinal muscle does not cross beyond the pyloric sphincter. This is also one of the reasons why the lymphatics don't cross, and hence the carcinoma of the stomach does not spread to the duodenum. Nerve supply, we have both sympathetic and parasympathetic. Sympathetic is from T6 to T9 segments of the spinal cord. From there, greater splanchnic nerves, the branches from the sympathetic, greater splanchnic nerves, they will come and relay in the celiac plexus, and from there they supply the stomach. So sympathetic is mainly vasomotor, then convey pain sensations, sense of pain when it is over distended, and it is inhibitory to the pyloric sphincter. Okay, sorry, it's not inhibitory, it is actually stimulates the pyloric sphincter. Parasympathetic is by vagus nerve. We have the right and left vagus nerve originally, but in stomach it is called as anterior and posterior vagal trunk. Right and left, because of the rotation of the stomach, it becomes anterior and posterior vagal trunk. Parasympathetic is stimulatory, increases the secretions of the glands and closes the pyloric sphincter. It is inhibitory to the pyloric sphincter. Okay, so improves or initiates the gastric motility, initiates the secretion. The anterior vagal trunk, more close to the esophagus and lesser curvature, divides into gastric and hepatic branches. Hepatic branch will again divide into an ascending branch which will go into the liver to the porta hepatis. Descending branch divides into an inverted Y shape, mainly supplies the pylorus of the stomach. The remaining gastric branches, they supply the stomach, and the main branch is actually called as the nerve of Latarjet, anterior vagal trunk from the left legs. Posterior vagal trunk is little bit away from the esophagus, and it also gives celiac branches, take part in the celiac plexus. Okay, because celiac plexus parasympathetic, it has a sympathetic, but it also has a parasympathetic component. Then it gives gastric branches, and the main branch, gastric branch, is actually called again the nerve of Latarjet. So mainly anterior and posterior vagal trunk, they are parasympathetic to the stomach. That is about the nerve supply of the stomach. And finally, we have come to the clinical aspects. So first thing, I think most of us would have experienced this symptom at some point of our life, gastritis. So inflammation of the gastric mucosa is called as gastritis. Irritation due to so many factors, over secretion of the acid contents, hydrochloric acid, or due to some infections, or sometimes any injury, all this might lead to gastritis. Usually gastritis heals on its own, and the pain is felt along the epigastric region. Now, when the mucosa is actually damaged, and that is actually called as the gastric ulcers, when it is chronic, repeatedly occurring, The hydrochloric acid damages the mucosa, and naturally what happens, it creates, you are able to see here, these are all the gastric ulcers which have eroded the mucosa wall of the stomach. It may lead to bleeding, gastric bleeding. Now, this might be due to this, also called as peptic ulcers, mainly in the stomach. They occurs because the defense mechanism of the mucosa is not proper. One thing, the mucus secretes, which is watery as well as it is gel-like, and that gel-like substance is most intimately applied to the wall rather than to the lumen. Then, if the bicarbonate ions are not secreted properly, okay, then if the tight junctions of these cells of the epithelium are not well enough to protect this wall of the stomach from the harmful effects of the hydrochloric acid, then it leads to gastric ulcers. So you get pain, burning sensation of the stomach, belching, you belch a lot, all these things. If it left untreated or if it worsens or aggravates, it might actually perforate your stomach wall, and naturally mostly the posterior wall perforation, bleeding might take place into the lesser sac, and it might also prove fatal. That is one thing. Sometimes what happens is the erosion of this mucosa epithelium, the mucosa rebuilds again, and sometimes it might become a gastric carcinoma, cancer, CA stomach. Okay, that might also lead to cancers of the stomach. In cancers of the stomach, Preusser sinus signaling nodes, they are left supraclavicular nodes enlarge. Enlargement of the left supraclavicular nodes is called as Preusser sign. So in the initial stages of gastric carcinoma, you can see these are the first nodes to enlarge. It is called as Preusser's sign. So selective vagotomy, if any medications or any treatment options are not giving fruitful results for the gastric ulcers, then you go to selective vagotomy, and what happens is you actually cut the gastric branch of the vagus nerve, the nerve of Latarjet. The pyloric branches are spared so that it does not interfere with the gastric emptying. So you can cut even the main trunk in the selective vagotomy. If it is not performed, it is not advisable, or it is not going to give any relief to the patient. You go for truncal vagotomy. So the main trunk, anterior or posterior vagal trunk is cut. Nerve of Grassi, it is also called as criminal nerve of Grassi. What happens is the posterior vagal trunk, it gives a branch to the esophagus, gastroesophageal junction, well above at a higher level itself before entering the stomach. This nerve might be missed in case of the vagotomy, and naturally what happens is again it might produce gastric ulcer. So you should see whether this nerve is present and see to that even this nerve is severed, and it is called as criminal nerve of Grassi. Too much of gas, if the fundus is dilated, the summit of fundus might reach the fifth intercostal space I told you. It might produce gastric symptoms, mimic the symptoms of a cardiac pain. Thickening of this muscle, pyloric muscle, circular muscle, is actually called as pyloric stenosis. So emptying of the contents is not proper. In children, newborns, you can see congenital pyloric stenosis, which leads to projectile vomiting. So when you feed, immediately what happens, the contents are vomited and it is in a projecting form. That is called as pyloric stenosis. So you go for pyloroplasty. So surgically what happens is you repair the pyloric sphincter. That is called as pyloroplasty. So that is about the stomach for today. Thank you very much for your patient listening.